Bueno, muchísimas gracias, doctor Pedro Ruiz. Yo creo que esto ha sido algo muy ilustrativo y enriquecedor para todos, porque a veces no conocemos la interioridad y las estructuras internas de asociaciones tan importantes y la madre, que es la Asociación Mundial de Psiquiatría. Nuestro último ponente, una persona muy importante de Turquía, el doctor Levent Kuey. Él es profesor de psiquiatría desde 1989. En el 1993 comenzó como terapista asistente del grupo de psicodrama y trabaja como docente de investigación por más de 30 años. Ha trabajado y publicado en diferentes temas psiquiátricos: depresión, ansiedad, epidemiología psiquiátrica, formulación de casos, psicopatología, clasificación y diagnóstica. Del 2008 al 2014, secretario general de la Asociación Mundial de Psiquiatría, es miembro del Comité Ejecutivo de la Asociación Psiquiátrica Europea, pasado editor y miembro del Comité Científico de revistas psiquiátricas, de diversas revistas psiquiátricas internacionales de su país, miembro fundador y pasado miembro del Comité Ejecutivo de la Asociación Psiquiátrica de Turquía y pasado miembro del Board de Honor de la Asociación Psiquiátrica de Turquía. El doctor Kuey va a hablar sobre el diagnóstico como proceso de reconstrucción conjunta, cómo puede ayudar a la teoría psicodinámica. Quiero hacer una salvedad: el doctor va a hablar en inglés, no hay traductor, aunque yo sé inglés. Va a hablar muy despacio, si en algún momento no se entiende, al final podemos aclarar. Yo estoy presente, el doctor Belfort también, y podemos ayudar con el tema. Con ustedes, el doctor Levent Kuey. Gracias.
Muchas gracias, Dr. Nina, and thank you very much for coming here in this beautiful weather. I hope you would not be disappointed. Thank you very much, Edgar, for organizing this session, and thank you muchísimo gracias to Pedro Ruiz, who has been leading us in WPA very efficiently. I'm the Secretary General of WPA, and I have been working for WPA for the last 6 years, and I'm the editor of the website. After you go home from here, please, before going to sleep, if you want to surf the internet, go to wpanet.org, where you will find all the information about WPA. When we were preparing this session, I thought it might be interesting for you if I bring some ideas and a case story. I will present you some ideas on our clinical practice from a different perspective, and I will present you a case story. In fact, one of the discussions across the world is about psychiatric training, psychiatric education, is the issue whether psychodynamic or psychotherapeutic training should be included in psychiatry residency or not. The main idea, mostly in European countries, and I'm sure in Latin America too, is to have some basic psychodynamic approaches included in the psychiatric curriculum. Because although many of the psychodynamic techniques or psychoanalytical therapy do not help to treat, but it really helps to understand in most of the cases. Anyhow, so I brought you, I'm sure many of you would remember your first bicycle. I've never forgot my first bicycle. It's always important in our lives. The first bicycle, usually bought by our parents after the first or second grade, if we have nice notes, nice grades. So this, first I will tell you a story of one of my patients from many years ago, and I call this story White Bicycle. Of course, as all psychiatric case stories, it's tragic. This is a story about a girl and her first white bicycle. But first the setting. Where does the story goes on? It was autumn about 20 years ago, a couple weeks before the schools had started. Izmir is a city on the western coast of Anatolia by the seaside. We have nice plages also. And it was late summer and a nice weather. A person, a lady of 38, had just dropped herself into the chair of a psychiatric consultation room of an outpatient clinic as the first afternoon patient at 1:30 p.m. She was complaining of total sleeplessness and asking for strong medication. The clinician's first impression, I was a clinician, I was a psychiatrist, first impression confirmed the complaint of the lady. She really looked as if she had not slept at all, with full red eyes circled with dark shades, along with a deep, sad expression, as if frozen at her face since many years. She said that she's an elementary school teacher, married to a man of the same profession. They had immigrated to Izmir from a far east Anatolian city, Kars. It's in the Russian-Turkish border on the northern east part of Turkey, a city which is under snow for about 6-8 months in a year. And these couple, after working there as a teacher, they wanted to move to the west, which there's a better life quality, of course, and they had managed to migrate to Izmir 3 months ago. At June, when the school term was finished, they happily moved to Izmir with their 11-year-old daughter. They had been hoping for this move for the last couple of years. Just the day after they had moved to Izmir, the daughter and the father went to buy a bicycle for her because she had been asking that as a gift for her graduation from the elementary school. Actually, she had graduated 3 months ago from the elementary school, while they were still living in Kars. But she had to wait for a white bicycle until they had moved to Izmir, because in Kars, it was a more of a conservative town. The parents had thought that it would not be socially accepted for the young daughter of the teachers going around on a bicycle in a small conservative community. So most of the girls of the region at that age were preparing themselves for marriage. You know, marriages in conservative societies are still quite young for the ladies. So she was very much looking forward to moving to Izmir, not to only to move to Izmir, but also to have the chance of having her freedom of riding a most dreamed of white bicycle. The clinician, talking about me, at this nice weather during the noon break, the clinician, aged 36 by then, I was young by then, went out for a light lunch with his close friend, a neurosurgeon. We had gone out for a light lunch, and after lunch we had time to play some backgammon, and we were also chatting about our daughters. I also have a daughter. The daughter of the neurosurgeon, age 7, had developed enuresis nocturna, and the clinician was helping her to overcome this problem. They were discussing what could be the proper parental attitudes and behaviors in this situation. The neurosurgeon also revealed his own problems of enuresis of his childhood and his parents' threats of planting him in the toilet all night long. Issues of transgenerational transmission went far beyond the end of the backgammon game. So these two doctors, psychiatrist and the neurosurgeon, were chatting about their daughters. On the other hand, the psychiatrist's daughter, aged 4 by then, had also some health problems lately. She had a virotic infection of upper respiratory tract a couple of weeks ago and developed a febrile convulsion. early in the morning while her father was trying to cool her down under the shower. It was really hard and traumatizing at times for both the daughter and the psychiatrist, the clinician. After the convulsion was over, father took her to the hospital with his fellow neurosurgeon. They both did their best to help her compassionately. When taken back home that evening, she was feeling better and slept peacefully at first. But her body temperature was fluctuating, and her parents followed up and continued cooling her in case of need in rotations all through the night. At one break, the father had a chance at last to hide himself in a room for a while where he welcomed his tears and cried. Tears made him to recollect an old childhood memory. He was around 6, and just after a febrile sickness of about a week, his father gifted him a red football. He was allowed to go out to play with his friends on the street happily again. He had missed to kick a ball for so long. So one hard kick made the ball to fly over the garden wall of a house nearby, and the kids started screaming for the ball to be thrown back. The wall was too high for the kids to see what was going on in the garden. They shouted till the bottom of their voices. After a while, as if a year for the kids, someone started shouting back from the inside of the garden. It was the voice of the owner of the house, an old lady. "Didn't I tell you not to play in front of my house? You are making so much noise. I'm tired of you. Here is your ball. Get your ball and your ass out of here. Go to hell." Yes, the ball was thrown back, but with a big knife cut on it. That lady didn't like the kids anyhow. The kid, later to become the clinician, gave a hug to the torn ball and ran to his hell. Entering home and without saying a word to anyone, he found a room for himself under his bed to cry and welcome his tears. Yes, the later clinician remembered this memory of his red ball while struggling to help her daughter. Well, in a week, the daughter recovered and the clinician also. But of course, with the painful prints of this experience in their own emotional libraries, written on the clay tablets, were experiences of loss and threats of losing were printed. Now let us go back to the clinical setting. Remember the lady. The lady put her papers on the clinician's desk and with an angry voice exclaimed, "I cannot sleep at all, I want medicine." First words of the clinician came out to be as, "What happened? Did you lose your sleep?" Answer was very striking. No, I did not lose anything. I want to sleep. Give me my pills." Clinician, "Your pills?" A tough, confused rejection again. No, but yes, I want pills. I meant a strong medication to make me sleep. "Well, okay," said the clinician. "I will help you with your sleep, but please tell me, what is this my pills issue?" Insisted the clinician. The lady went into an outbreak and started crying and shouted, "I want my daughter back." During the interview, in due course, it came out that a week before, her daughter, while riding her bicycle near their home, was hit and killed by a car on her first bicycle, the driver of which was an unlicensed 17-year-old boy. It was the tragedy of the mother. The clinician could manage to go on with the interview, which was not easy, and eventually they could reach a compromise that she will come to see him again next day. The clinician, contrary to his usual practice in grief situations, also advised her to take 10 milligrams of amitriptyline every night. While he was filling out the forms and handing out the prescription, she hesitated and asked with a shy, low tone of voice, "What color are these pills?" "White." "Then I will take them." There was an agreement constructed. After the patient had left, it was not easy for the clinician. The clinician locked the door from inside, took a deep breath, and held his head in his hands and tears in his eyes. Rereading and reconstructing his own clay tablets once more, where his own experiences of loss and threats of losing had been printed. That was the white bicycle story. Let's go back to our question at the beginning. How can psychodynamic theory help us to, in our practice of diagnosis and treatment, which we should take as a joint reconstruction process between the clinician and the patient? I have about 10 more minutes to talk. As you know, in our clinical practice, we use different methods, different tools to understand our patients. Observation, objectivity, subjectivity of us as the clinicians, and subjectivity of the patient, her or his narrator. Empathy, transference, and counter-transference processes help us to understand the patient. Although there are many psychoanalytically oriented psychodynamic schools and therapies, some core common issues that may be relevant to any daily diagnostic practice may be stated. What are the commons? The main focus of our clinical work is on emotional pain. Life is considered as a difficult and demanding process, and psyche is constructed and reconstructed in the struggle to deal with the problems of life. So what is dynamic here? The turbulence created in the currents of mental life of these struggles. So we develop means of avoiding pain. Ways of seeing, thinking, feeling, and behaving can all serve this purpose. Much of this activity takes place out of our awareness, which is our internal world, subjectivity, and constituted differently from the external reality, objectivity. The unconscious elements of this internal world have a fundamental influence on our lifestyles. These unconscious attempts to avoid pain often fail, but since our awareness is limited, they are nonetheless repeated and repeated again, repetitive phenomena. Failing defenses of these repetitive patterns give form to maintain patterns of psychological disorder. Therapy is about getting in touch with thoughts and feelings which are previously put in the library of clay tablets, mostly kept hidden from the conscious mind because they seem to be too much to deal with. Psychodynamic therapy is about helping the person to reformulate or to reconstruct what they are experiencing in a more inclusive way and to tolerate the discomfort that this involves. The ongoing joint understanding and reconstructing processes that the therapist and the person develop about these difficulties expand the person's awareness. So through the therapy process, it's expected to open up new options for recovery, resilience, and conflict management. The person's capacity to bear emotional pain and cope constructively with dissatisfaction is enhanced, and the ability to reflect on and be curious about their own experiences is developed. This understanding of psychodynamic perspectives may be helpful in our daily clinical work, where we try to find answers to a fundamental question. In our clinical work, the first question that the clinician has in his or her mind is, how can I collaborate with this person who has an emotional pain to diminish his or her suffering and to reconstruct his or her integrity this needs a collaborative effort between the clinician and the patient. At this clinical encounter, where the personal emotional tablet libraries of the two meet. Of course, the clinician has also a memory, has also a past, and any interview triggers these tablets of the past of ourselves, which we should be aware of. A challenge for the clinician at this point is to harmonize the current available scientific universal knowledge, objectivity, and with the uniqueness of that specific person who had consulted us. At this point, an epistemological approach, constructivism, may be helpful, because neither objectivity or subjectivity is enough by itself for the clinical work. Objectivity makes the patient as an object of research. Subjectivity forgets about the objective universal scientific knowledge, but constructivism is kind of combines these two approaches and takes care of the clinicians as an objective observer, but also as a person who has a subjective past. So in our efforts, in our clinical practice, our focus is building a joint, ongoing reconstruction process of diagnostic assessment, formulation, and care and treatment with the clinician and the patient together in a collaborative effort. Thank you very much for your attention.